Okay, to talk about the thorax, we're going to start with the anterior thoracic wall and describe its structure and answer the what questions. What muscles comprise the anterior thoracic wall? What structures comprise thoracic skeleton? And what nerves, arteries, and veins supply the anterior thoracic wall? Okay, so first, thoracic muscles divide into two different camps. One, superficial muscles that support the upper limb, and deeper intercostal muscles that support the thoracic cage. This sounds similar to the back. Superficial muscles, upper limb, deeper muscles, axial skeleton. All right, so here we have the first superficial anterior thoracic wall muscle, which is the pectoralis major, outlined there in orange. And this pectoralis major arises from the clavicle, sternum, and also the ribs, and then it attaches laterally to the intertubercular groove of the humerus right there, along with the lats and teres major. And so this muscle is going to help flex and adduct and medially rotate the humerus. And this picture is only showing the flexion of the flexion and some adduction of the humerus. Now, the innervation is through the medial and lateral pectoral nerves. And so to show that, we need to show the C5 through T1 spinal cord levels, and then show the brachial plexus, which is the network of nerves supplying the upper limb. And so the lateral pectoral nerve arises from the ventral horn of C5, C6, and C7. The motor neurons course out through the brachial plexus lateral cord, and there's our lateral pectoral nerve. The pec major is also innervated by the medial pectoral nerve that arises from the ventral horn of C8 and T1, and those motor neurons come out the medial cord of the brachial plexus as the medial pectoral nerve. So both of those nerves cause the pectoralis major to contract. Next is our pectoralis minor, and minor because it's smaller than the pectoralis major. It's also located deep to it. And this muscle arises from ribs 3, 4, and 5, and then its distal attachments along the coracoid process of the scapula, along with the short head of the biceps and coracobrachialis muscles. And this muscle helps to stabilize the scapula, as shown in this picture of someone halfway doing a push-up and then they pause. It also helps slightly with protraction of the scapula. Now, the innervation of the pectoralis minor is from the medial pectoral nerve that arises from C8 and T1 spinal cord levels, using one of the same nerves as the pec major. So there's our brachial plexus, and there's our motor neuron cell bodies in the ventral horn of C8 and T1, and then those axons come out the medial cord of the brachial plexus, and there's our medial pectoral nerve going to the pec minor. It then pierces the pec minor and goes through to innervate the pec major. So to show that, we take a look at this picture here, okay? And there we're going to highlight, we can see the pec major and pec minor. And that arrow is showing the lateral pectoral nerve coming off of that lateral cord. And you see that that nerve going to innervate part of the pec major. Now the pec minor is innervated by the medial pectoral nerve as well. That medial pectoral nerve does both the pec minor and pec major. So here we can see the medial pectoral nerve coming off of the medial cord of the brachial plexus, goes and innervates the pec minor, pierces through its belly, and continues on to innervate the pectoralis major muscle. All right, now the serratus anterior gets its name because it looks like it's got a serrated edge like this, where you can see it interdigitating with the external oblique, and also on the other side where we've removed all the muscles, and you can see it's got that serrated appearance on the front of the ribs. If we look along from the side, we see that this serratus anterior arises from ribs 1 through 8. And then it has a distal attachment along the medial margin of the scapula, which is why I use those dotted lines to show as if you're looking through the scapula. We can also see that in the superior view in this osteology if we highlight just those attachments of the the serratus anterior coming from the anterior ribs, and then it courses to the medial margin of the deep surface of the scapula. Now this muscle, serratus anterior, will help with protraction and stabilization of the scapula. Protraction from here to here. Another word for this is abduction of the scapula. It also helps with stabilizing the scapula like the pec minor is showing in this picture. Now, the innervation of the serratus anterior is from the long thoracic nerve, which arises from C5, C6, and C7 spinal cord levels, and it also courses through the brachial plexus, and so the motor neurons arise, and it's the long thoracic nerve, that's the branch indicated. And so there's our motor neurons. And so you see them coursing down through this long thoracic nerve to innervate the serratus anterior. Now, this is an interesting nerve because it's one of the few nerves and the only nerves that I can think of in the body that courses on the outside of the muscles. So if we focus in on here, there's our long thoracic nerve as it courses down external to the serratus anterior and innervates it as it goes. As a result, this nerve is prone for injury, especially for any types of surgery in the axillary region like a mastectomy. It's one contraindication that you can actually hurt that nerve. All right, so next we have our deeper anterior thoracic wall muscles, also known as our intercostal muscles. And so there's first the external intercostal, internal intercostal, and innermost intercostal. And these three layers of muscles are called intercostals because they are between costal ribs. And they arise from the inferior border of one rib, and then they attach to the superior border of the infra-adjacent rib. And the actions of these muscles are as follows. Well, the external intercostal helps with elevation of the ribs. So this picture shows the external intercostals, and shing elevates the ribs, as in inhaling, and then they relax for exhaling. And so the elevation of the ribs is from the external intercostal muscles. Now, internal and innermost intercostals, my notes say depression of the ribs. A lot of books will say this. To be honest, I don't even know if they really do a whole lot of that. And when we take a look at this internal intercostal and innermost intercostal, primarily when they contract, they just keep that surface tight so that when the parietal pleura is, that it has this very sharp, not sharp's not the right words, a tight place for this parietal pleura to bind to. And so it doesn't become weak in those areas. That's its primary purpose. Now, these intercostal muscles are segmentally innervated by intercostal nerves. So there in yellow is an intercostal nerve, and it sends off these motor neurons to the external intercostal, internal intercostal, and innermost intercostal muscles. Now, the thoracic skeleton is basically comprised of 12 pairs of ribs, which articulate posteriorly with the 12 thoracic vertebrae and anteriorly with the sternum. And these true ribs, the first 7, are ribs 1, 2, 3, 4, 5, 6, and 7. And they're called true ribs because each of the bony part of the rib and its associated costal cartilage pair up individually and are attacked and articulate with the sternum. Whereas the false ribs, ribs 8, 9, and 10, notice that each of those bony elements all together, ribs 8, 9, and 10, those 3 different articulation ribs, those 3 different segmental ribs are going to send their costal cartilage joined together to then articulate with the sternum. Now, the floating ribs, ribs 11 and 12, they're called floating ribs because they do not articulate with the sternum. The manubrium is the upper bone with regards to the sternum. It actually articulates with the clavicle and rib 1. And then between the manubrium and the sternal body is something called the sternal angle because it makes this approximately 163-degree angle. It's not very prominent, but it's enough that you can palpate with your fingers. And it's an interesting one because at the sternal angle, if we go across horizontally, and then count vertebrae, T1, T2, T3, T4, and T5. So if you go from the sternal angle horizontally, you're going to go between the T4 and T5 vertebra. And this is a very classic landmark called the transverse thoracic plane where you see the following things. So if we look at table 2.1, we'll see at the sternal angle, the second rib articulation, the azygous vein arching over the right primary bronchus, the jumping into the SVC, the trachea bifurcates, the pulmonary trunk branches into the pulmonary arteries. You'll find the level of the ligamentum arteriosum, the beginning and ending of the aortic arch, the thoracic lymphatic duct crosses from right to left in the thoracic cavity. A lot happens at that level of the sternal angle right there. Now, the sternal body forms the major body where costal cartilage is from the rib cage articulate, and then the xiphoid processes this pointy inferior projection on the sternum. So the nerves of the thoracic wall, the major ones are the intercostal nerves, and they course in the intercostal space. They provide motor to the intercostal and anterior lateral abdominal wall muscles, and their sensory is the skin of the anterior thoracic and abdominal wall, as well as the deeper serous membranes. So here we have, let's see, coursing in the intercostal space. Shing! You see that nerve coursing in that intercostal space between the internal intercostal and innermost intercostal muscles. And so here we have again in the coronal section, and where just at the bottom of each rib in the intercostal space is where you're going to find this intercostal nerve and the vein and artery. Now, the motor of the intercostal nerves, as mentioned before, is the external, internal, and innermost intercostal muscles, as well as the abdominal muscles. And sensory is to the anterior lateral thoracic and abdominal wall. So here we have at each segmental level, these dermatomes are innervated by their associated intercostal nerve, as well as the deeper serous membranes, in this case, I think showing a pleural sac there. Now, the vasculature of the thoracic walls are as follows. The intercostal veins are next. And so those intercostal veins arise from the following. We have these anterior intercostal veins shown at those locations, and that blood is draining towards the heart, and so those segmental anterior intercostal veins drain into this internal thoracic vein, which ascends up and dumps into the brachiocephalic vein on either side. This will happen, it's bilateral symmetry, and the brachiocephalic vein drains into the superior vena cava. Now, the posterior intercostal veins also appear at each segmental level, and their blood's draining towards the heart, but the right and left side of the thoracic cavity are different. On the right side, posterior intercostal veins drain into the azygous vein, which ascends and dumps in to the superior vena cava. Whereas on the left side, posterior intercostal veins drain into the accessory hemiazygous and hemiazygous veins, which both dump into the azygous vein, which dumps into the superior vena cava. Now, the intercostal arteries shown here are also found in this intercostal space, and these intercostal arteries arise from the internal thoracic artery, which comes from the subclavian arteries, on both sides. And this internal thoracic artery courses down, and at every segmental level, it gives rise to an anterior intercostal artery that serves that space. And additionally, the thoracic aorta, which descends down the thoracic cavity, gives off these posterior intercostal arteries at every segmental space, and it also supplies its associated segmental level muscles, overlying skin, and parietal serosal membranes. Now let's talk about the diaphragm. So the diaphragm arises, it's located between the abdominal and thoracic cavities, and it attaches to the xiphoid process anteriorly, the ribs and costal cartilage laterally, and T12 to L2 vertebrae posteriorly. And these muscle fibers insert on a central tendon. And so in this picture on the other side, we can see the right crust and the left crust, which are these posterior anchors for the diaphragm. And then we see this dome-shaped appearance that the diaphragm makes. So the diaphragm is innervated by the phrenic nerve. So there we take a look at the spinal cord and see C3, C4, and C5 spinal cord levels. And we remember it is C3, 4, and 5 keep the diaphragm alive. And so we now draw out that phrenic nerve bilaterally as it's going down to innervate motor-wise the diaphragm. And so the functions of the diaphragm are as follows. There's the diaphragm relaxed, there's it's contracted. Relaxed, contracted, relaxed, contracted. In other words, when the diaphragm is relaxed, that's the expiratory position of the diaphragm. When the diaphragm is contracted, that's the inspiratory position of the diaphragm, or what the diaphragm looks like. It contracts to allow you to inspire or inhale air. And so when the diaphragm's relaxed, there's a thoracic volume decrease. But when the diaphragm contracts, there's a thoracic volume increase. Relaxed, contracted, or relaxed, the breathing in and breathing out. So to review the anterior thoracic wall structure, we have thoracic wall muscles that act on the upper limb and intercostal muscles. We also have the rib cage and sternum that help provide the bony and cartilaginous structure. We have intercostal arteries, veins, and nerves. And we also have the diaphragm that helps for breathing. And that, my friend, is an overview of the anterior thoracic wall.